We are not trying to build silos and fences around and saying that we own patient data. We take our role as a steward very seriously, and we just try to be the highway. So like, how are we getting the information where it's going to be used and maximized? And we hope in conducting ourselves this way that policymakers and the various vested interests in the conversation will feel calm about it, feel confident that the pharmacist is going into this new practice area using the best standards a physician or a laboratory would use. And it's not seen as a threat, but it's seen as an opportunity.
Welcome to Personalized by Vitamin Lab, the show where we dive deep into the world of personalization in healthcare. I'm your host, Dr. David Dizer. Please remember that the following discussion is for educational purposes only, and it's not intended to diagnose or treat any disease. Speak with your healthcare practitioner first before integrating anything that you learned today. Join us as we explore the remarkable stories, breakthroughs, and possibilities that come with the pursuit of personalized healthcare. Welcome to Personalized, the podcast where we explore the cutting edge of personalized healthcare and how innovators are empowering individuals to take charge of their well-being. I'm your host, Dr. David Dizer, and today we're joined by a trailblazer in this field, Hector Bremner. Hector is the CEO of Avricore Health, a company revolutionizing pharmacy services with their flagship platform, HealthTab. By bridging rapid testing and actionable health information directly to community pharmacies, Hector and his team are making proactive healthcare more accessible than ever. With a career spanning business development, public affairs, and strategic communications, Hector has a unique ability to bridge the gap between innovation and real-world impact. From supporting nonprofits and First Nations to advising on public policy, his work has always been about creating solutions that serve people first. Join me as we dive into Hector's journey and explore how Avricore Health is leading the charge to transform how we access and engage with our health. This is Personalized. Enjoy the show. Welcome back to Personalized. I'm here with Hector Bremner. Welcome to the show, Hector.
It's a pleasure, as always.
Thanks for being here. I'm really excited to speak with you because, as you know, I've got an obsession with agency in healthcare. I think it's quite important, and this is what your company does. And I'm interested to learn more about you, about Avricore and HealthTab, and how you're influencing the health of those worldwide. Can you tell us a little bit about your company?
Thanks, David. As I say, it's always great to connect and share the mission, because I think we're a very mission-driven enterprise. I don't think you can work in and around healthcare without having, obviously a broader vision than simply just, punching a clock and going to work in a day. You're trying to affect change, and you're very much focused on a bigger picture. And, my background, having prior to getting involved with this company, was in politics. And so you leave politics and then you think to yourself, like, what am I going to work on that's going to invigorate you in the same way? And HealthTab did that for me. And I was really honored to be asked to get involved with Avricore as the CEO there and lead the company through a bit of a changeover. The original concept behind the company, I think, was to bring technologies forward into the community pharmacy setting, where the company was originally started by a group of pharmacists were people with pharmacy background that understood that the pharmacy practice was changing, that there was some really interesting pioneering ways of being able to address health concerns in the pharmacy setting, where they had been for a long time really stuck on simply dispensing drugs, right? You come in, you have your prescription, we dispense the drug. We provide a limited amount of advice, but as we've seen folks have lower and lower access to primary care from their GP, they've obviously needed to seek out other ways of accessing care. So you're seeing the allied health professions play a bigger role, and pharmacy is interesting because they go to conventional medical school, the really different, the diversion between a pharmacist, who many of which have completed the doctorate of pharmacy. So they're going quite deep into the schooling. They focus on the chemistry. They don't do the practicum work. So they're not doing the hands-on medicine, but they're focusing on the chemistry side of the medicine. However, they're really well positioned. And we learned that during COVID, that when you needed to access primary care, they were there. They're trusted. The public deeply trust their pharmacists, and they've always been sort of overtrained and underutilized. And so that was the mission statement behind Avricore, and as this vision of saying, well, they want to do more, they can do more. What do they need to do it? And so one of those technologies was HealthTab, and that was acquired. And the gentleman that created it is still working with us today, Roger Seckham. And we have a platform in HealthTab that is an end-to-end solution for point-of-care testing for the management, of course, screening and management of chronic disease, and chronic disease being one of the key areas where your pharmacist can really help you, because they see you routinely, you're picking up your medications. It's an ongoing issue, so it's not necessarily at any particular moment a crisis, but it very quickly can become a crisis. We certainly find a lot of people that are in late stage of cardiovascular disease that are at risk of a heart attack and stroke. So how do you focus on early intervention? Well, you can't improve what you don't measure. So point of care testing and the use of the pharmacy is a fantastic way to deploy at a scaled level the type of screening and management and community health approach that you need to take the pressure off of the conventional healthcare system, and particularly the hospitals and our ERs and our acute care beds. So it kind of encompasses where our thought process and how our technology fits within our thought process.
Right. Well, thank you for that. What markers are measured on your test?
So there's up to 21 biomarkers that we're measuring, but the easiest way to think about it is it's a full lipid panel. So it's giving you things like your good and bad cholesterol, of course, your triglycerides. It's also our software is interpreting the result off the instrument. The instrument is provided by a third party. We have used instrumentation that is typically found in a small lab or in a remote healthcare setting. These instruments were designed to be essentially laboratory grade, but in a laboratory that you're doing hundreds or maybe thousands of tests at a time, right? They're meant to do large, but these instruments just do one test, one patient at a time. And so the genius behind it is taking these instruments, which typically are a little bit too expensive for a pharmacy and a little bit more complex for a pharmacy. We make it easy by connecting it to our software, which interprets the result out of the instrument, because there's a customized health survey that's required to understand a variety of aspects of the patient's history and who they are in order to get an accurate result. And so we'll using in Canada, the Framingham risk score, for example, or in the UK, they have something called Q risk, which is quite an involved right down to your postal code analysis of your heart disease risk. And so we're applying that, and we're giving you a quick and easy, as well as the healthcare provider, a quick and easy interpretation and understanding of your current status in relation to cardiovascular disease, but also diabetes. And diabetes is another area of major concern globally, given its virtually out of control rise in rates in the population. And that disease, many of your audience will know, is the gateway disease. If you have diabetes, you're much more higher likelihood of liver and kidney disease, certain cancers. It goes on and on and on. So the big focus for healthcare, certainly from the patient perspective, and I think increasingly from policymaker perspective, is to say, how do we get away from the disease care model, which I think we've pretty much entrenched, where we wait until something breaks, we wait until you have the stroke, we wait until you need to be on insulin, which of course is expensive. It's a huge drag on the economy, not to mention the cost in life and quality of life. And how do we intervene earlier? How do we encourage you and nudge that patient if they're not in a crisis position yet, and nudge them in the right direction and either delay or avoid the worst outcomes? And conversely, I can tell you that we are finding a lot of very sick, undiagnosed people, and 70% of the people that are caught using HealthTab that are in a full-blown diabetes state that are undiagnosed. It's about 6% of people that we're catching. 70% of those individuals are actually attached to a family physician. So it speaks to the fact that healthcare is not necessarily about more or less money or necessarily about finding efficiencies. It's about what is the lowest barrier to access to care? Where's the thing that's most convenient for that individual to access care? And how do you give them the right information at the right time? And I think in listening to some of the policy statements as late from like the Canadian Medical Association and others, it's like it's the right practitioner at the right price at the right time. So we did this in the hospitals where the physician was being bogged down by administrative work or doing certain activities that were just not the highest testing use of their time. Like really, they should be doing diagnosis and direct treatment. But in the hospital setting, you have the nurse practitioner, you have a variety of specialist nurses and other care team members that it is better for them to, in a higher and best use of their time, to be focused on that work, and then the physician hours are freed up. However, we don't do that in community care. So the physician, everything goes to the physician's office. And policy has been changing, going in the right direction in Canada, and is being very aggressively changed in the UK. And so we see a really bright future for what we're doing there and in continental Europe. But the bottom line is, as everyone in your audience will know, healthcare is in a crisis. So you can't just keep shoveling money at it. If shoveling money out the door was going to solve the problem, I would have solved the problem a long time ago. Chronic disease is the fastest growing areas of cost. And so if we can intervene early, managing community, we can save potentially billions of dollars.
Oh my gosh, absolutely.
Dumping a lot on you at one time. I hope I'm not unloading too much.
No, it's the best. It's the best. We've got an audience here of integrative practitioners, medical doctors, naturopathic doctors who are interested in private primary care and the influence that autonomy in healthcare can have. They're probably wondering about what the patient experience is like. Like you go in, you say to fill out a survey. What happens next?
So the workflow from a patient point of view is that you may have been contacted by your pharmacist because you may be on some medications that they have a high likelihood of having chronic disease. So they're encouraging people to come in and what they do is a consultation with the patient. So you create your Health Tab account. You can create your Health Tab account at healthtab.com. Very quick and easy to create. You can do that in advance of arriving, or you can do it on site. The pharmacist will walk you through the process, and the customized health survey is within the process of taking the test. So you will be saying answering questions, for example, obviously things about unique to you, so age and gender and race and things of this, because there are some statistical aspects that affect the calculation of what the result means to you. But also looking at things like, has a family member in the last year had a heart attack or stroke, and all this impacts the math of coming up with the right result for you. Once you go through that, the test itself is taking about 10 microliters of blood, so it's a very small amount of blood, and then we're able to collect the sample. We can do the full lipid panel and the HbA1c off one draw of blood, so it's very comfortable for the patient. It's minimally invasive. To run both tests, it takes about 10 minutes. But again, there's a consultation going on and reviewing the patient's medication, how they're feeling about their health, answering questions and going through things. And then the results are produced in real time. Those results are shared to the patient's Health Tab account. So they have access to this information going forward. They can go back and review their information at any time that they want. When you're clicking through the user interface, it gives you sort of a red, yellow, green. So if you use something like 23andMe, or if you've done any sort of pharmacogenomics testing for yourself, it's giving you sort of insights of, this is a red flag, this is a warning, you're okay. As you add more results over time, as you come in and do more testing over time, it will obviously show you how you're charting over time as well. So helps both the patient and the provider create some consistency in the conversation with the patient. And also we can click through and there's some pop-ups and some information in there that tells you more about what the result means to you and what some potential care plans could be or some type of action you should take. We'll be adding even smarter interpretation in the first quarter of 2025 as well. So that interpretation will go even deeper. Wow. And so we don't want to replace, of course, the practitioner. We've as a company and team, we really thought long and hard about, first of all, I will say, by the way the term AI is used, you could argue that it's already using AI to interpret the result, but we haven't really flogged that in the same way as some other companies have. That said, we will be using some large language model algorithms within the software as a new iteration that will give a little bit deeper dive, and that's not, again, seeking to replace the practitioner, but augment and speed up their interpretation of what's going on and support the care plan development. So all in all, the consultation will take 15 to 20 minutes, depending on how much time the pharmacist is taking with the patient and going through their questions. Patients obviously have a lot of questions, and your audience will be familiar that traditional medicine is usually like you get one question, it's 15 minutes. Is it broken? Is it not broken? Does it hurt? If it's not, doesn't hurt, then you're fine. And then you have to go. But the patient, the pharmacist is, and I think your audience as well, is much more interested in the patient's whole health. And so there's really great hope, I should say, in the scope of practice changes that have been given to the pharmacist over the last 2 years, where we've got minor ailments, for example, that's been highly successful. Provinces are reporting already an up to 10% reduction in ER visits, thanks to the fact that there is pressure being taken on. There is this new access point that you don't have to go to the ER. You can go to see your pharmacist for this issue and you can have it dealt with. Chronic disease, again, is in Canada is not necessarily been within the scope or hasn't been funded yet. And we're hopeful that is coming in Canada. But I can tell you in the UK, it has happened already. They've, over this last year, spent about 1.2 billion Canadian on this Pharmacy First program, which included not only minor ailments like they have in Canada, but also blood pressure screening and being able to direct the patient through cardiovascular health journeys. That has been wildly successful. The Confederation, the NHS Confederation rather, on I think it was October 16th, released a really fantastic report where they found that investment has been singularly the highest return on investment for any NHS investment in care. So they are already seeing, for every pound they invest, within 12 months you get £1 back. In 5 years, they expect £7.50 back. And when you add GDP into the mix, you're now talking £14 to 1
Incredible
return on investment. So, Teresa, and this is how you save public health care. You have to invest in preventative care. We shouldn't wait until the heart attack and stroke happens, where that's it. Often it can, per episode, $2 million per episode in care for that individual in the first year. It can be $250,000 a day to have that acute care bed dealing with somebody in that deep crisis. So, we're very focused in the next little bit on augmenting the healthcare system with this type of technology in the pharmacy setting. And we think that the math makes a lot of sense. And we're hoping to see more governments like the UK make further investments in this area.
I fully hear you. I think that prevention is everything for where we should be focusing right now. I've been studying about the impact of health promotion investments in Canada, specifically around exercise, and how although it has had significant reach in terms of depth, Canadians know that exercise is good for a person. There's no accountability there. There's no individualization. There's no personalization. There's no one to check in with. And Canadians have not gotten fitter since the investment started in fitness knowledge back in the 1970s. We haven't gotten fitter. And I think a big piece of that is not having someone to turn to for this. And I can see how in your case, in chronic disease prevention, specifically around the cholesterol management and diabetes risk reduction, how the pharmacist can be a great point of contact for a person.
You're absolutely right. And I think the reality is physicians already have demonstrated that as effective and as passionate about their work as they are. The reality is that factually, people go into their doctor's office for, let's say, eczema or something. They present in a way based on their age, their physical makeup, and just other things that the physician, based on their training and the literature and their experience, know that individual is like a 99% sure that they're going to have cardiovascular disease, something like hypertension, or that they may even be diabetic. And they say, okay, you're Here's your topical steroid for the rash. See you later.
Mm-hmm.
And they just let them walk out the door. And so if that's happening, they're certainly not there to do what, let's say, a personal trainer or a health coach is going to be able to do in terms of that level of personalization.
There's no time.
It is no time. And then, I had my own experience with that. Like, for whatever reason, genetically, I have high blood pressure. It runs in my father's side of my family, and I'm a pretty fit person, and I'm in decent shape. My VO2 max is in the top 5% of my age bracket. My resting heart rate is at 50. My heart is fine, but I have high blood pressure. And I have seen a physician for a bunch of different reasons, and they'll notice that I have high blood pressure, and they just don't say anything to me because they think, well, he's a healthy guy. He's fine, And so, the other issue here is not only the time and the amount of resources we have with respect to primary care from a physician point of view, as to what they're really supposed to be doing. But we also have sort of privatized in a way some of this key elements. And what I mean by that is that, I was elected here in Vancouver. I was on city council. I mean, one of the issues is that if you look at the age of most civic centers in a lot of cities, the public ones, they were built in the 60s or 70s. Or maybe you get the odd new one here and there, but it's few and far between. And why that matters is that public centers or the YMCA. I mean, I work out at the YMCA that's across the street from me. It's only for my wife and I, it's $50 a month for the two of us to go there, right? And you've got a full gym, and you can take all the classes that you want, and you can be as active as you like. The issue is that depending on the neighborhood, if you live in an affluent community, we know how inequitable access to care is. You can have a universal healthcare system, but it doesn't mean it's accessible universally. So if you live in an affluent community, you probably have a really great community center with a fantastic gym and a pool and all these kind of things. And, Canadian winters are cold. So, I don't know if you're getting 10,000 steps or going for a run in -40. I grew up in Saskatchewan, but, you're not outside very much at that time of the year. So you need indoor facilities in Canada. And so it's important to think outside the box. It's simply just a linear decision of the healthcare professional, but what kind of investments are how do we think about health, and how do we facilitate people? What investments from a public perspective do we make that guide people in the right direction? And one of the things that when I worked in provincial government, we worked on my colleagues in the health ministry. I was in the trade ministry, but my colleagues in the trade ministry, I was getting a lot of the political blowback on it. Was that we engaged in a smoking cessation program. So we were publicly investing in things like nicotine replacement patches and gums and things of that nature. And so, I'm being questioned by various people in various communities. Well, why am I buying this? Why are my tax dollars going to this? Well, within the first year of that program, there was nearly 70,000 people that quit smoking.
Wow.
And so, was that a worthwhile investment? You bet your ass it was. It was a fantastic investment. If you do the math on getting an individual who's 35 to quit smoking, by the time they're 65, they're a lot less likely to have cancer and emphysema and a variety of other health concerns, like cardiovascular disease in particular. And so we're going to have to think differently about solutions. And I have studied that a great deal, and I think that's what guides a lot of my approach to things. And I definitely encourage folks to get away from the fact that better healthcare outcomes doesn't mean more or less money for hospitals, that it's bigger than that, and that things that don't really seem like health decisions, like how we build and design communities, that we as all of it doesn't matter what your profession is, who's sitting here listening to this, you're still a member of this society, and we you still are a part of a community. We need to be supporting things that make our communities healthier, because we know that more equitable communities are healthier. We know that communities that have a more mixed resource base in terms of income mixes, we know, and they have the type of facilities that they need, they have better outcomes. We know that if we are, forcing everybody to live right next to a highway, they're not going to be healthy. And if they're also in very suburban communities where, sure, it's lush and green and you have lots of trees, but you got to get in your car to get, even the smallest of thing. And like, you just don't walk, right? Nobody even knows what the front of their house looks like because they just, they go out to the garage, they get in the car, they drive out the driveway. And then, you know what I mean? Like, they've never walked down their street. They lived in that neighborhood for 20 years. And so health is really needs to be a more holistic approach. But to close this sort of tirade on this is in talking about public investments that is specifically how Health Tab was deployed into pharmacy, was that pharmacy is often the only healthcare access point for a lot of rural communities in Canada.
Point.
And so we had this issue as well when I worked in provincial government. We also ran this program it was a giant failure looking back on it, unfortunately, but it seemed perfectly reasonable. It was called GP for Me. And we made a substantial investment in physician attraction to rural communities in particular. Essentially, it was going to cover the cost of your living. You were going to, get if you did your 5 years in that community, your student debt was paid off. I mean, full red carpet treatment. I mean, financially, it made a ton of sense. You go live in Prince Rupert for 5 years, which is a beautiful part of the world, small community, I get it, but no doctors took us up on this. The reality is that not to do general practice. And it's not just a Canadian or certainly not just a British Columbia problem. I mean, in the UK, where we're getting a ton of traction and we're putting a lot of our focus on right now, the fact is that only 25% of licensed physicians, practicing physicians, practice general medicine. That's the lowest in any of the major economies. The reason being is if you're graduating medical school, it's the cost of graduating medical school, and of course the competitiveness, even just to get into it, is so high that to come out of it, and in British Columbia, the latest deal is after your office expenses and staff expenses, they're taking a home $350, somewhere around that, which is a lot of money for a lot of people. But I think if you've done the level of schooling and the amount of debt and the expectation is like, I'm a doctor, I need to earn, I'm supposed to have like the Porsche and the boat and you know what I mean? I think there's an expectation of standard of living that I want to live. And if you're going into general medicine, you're now going to have to carry this debt. And if you're living in a city like Vancouver and, cost of living, and it's like, do you really feel like you got ahead? There's mid-level managers of the city of Vancouver that make $350. They don't have anywhere near the education. So, they do the calculus pretty quick and they say, well, if I specialize or if I go to the States, I'll make a lot more money. And that's been the challenge is part brain drain, but part is from a primary care point of view, the inefficiency of the graduating classes and the students that are being produced. You can't blame them. They're choosing specialization, but it's not necessarily something to criticize. And I'm not being critical. I'm just saying that it's as the Stoics say, the obstacle is the way. What is the way? And if the obstacle is that medical students are choosing specialization over general practice, then there's the opportunity for the pharmacist or the naturopath or a community-based nurse practitioner or other community allied, can the dentist do more? So this is the opportunity for a broadening of and rethink of how healthcare is delivered from a public policy point of view and a public investment point of view. And I think Britain, not because it's necessarily being super progressive, but it takes like 6 weeks to see a family doctor. As much as we complain in Canada, you can today in British Columbia go to a clinic without an appointment and you'll wait an hour or something like that, but you'll see a doctor. It's not the end of the world, right? But in Britain, that's just not on the card. So you have about 1,500 patients per GP right now, and so they have been forced to make these decisions. So this is human nature. We're often disinclined to make a change despite all the evidence that the crisis is coming. We usually like to wait until we hit the wall and then we make the decision and then say, oh, let's blame that guy for hitting the wall. But the reality is that I think it's now pretty clear, and I think the UK is leading the way in this, is that they're saying, well, let's not fall off the cliff. If we do want to save the NHS and we want the NHS to be there for future generations, we need to invest in preventative health. And to tie it back to something I was saying a minute ago around equality of access to care, what I'm really proud to see is that our systems are being deployed into areas of Northeast London where they are underserved communities, marginalized communities, communities that haven't had as well as or as equitable access to care. But they are seeing much higher disease rates and shorter life expectancy and much worse outcomes. And so I think all of us work in this generalized field of healthcare. And no matter how you do it, you want to be able to nudge things in the right direction. So this is what we're hoping to do, is that be an example of how you can make investments and get the kind of outcomes that I'm talking about, that think a little bit differently, but have a significant positive outcome.
Absolutely. Well, I love that as a data point, as a case study. But can we get some data analysis on the penetration here in Canada? Like, do you have a sense of how many tests you've done since launch? Like, when did it officially launch, become available for Canadians, and how many tests have you completed?
Well, this HealthStat was originally developed in 2013. It was way ahead of the curve. Pharmacists were really not allowed to do this work. By the time I got involved, HealthStat had been acquired, and I got involved in 2019. And from that point on, we had a really interesting journey. So I got involved in sort of late 2019. The company needed a reset in a lot of different ways. So we really focused the company around Avricore, around this asset being HealthStat. And I had a friend that was on the board of TELUS, and they said, "Hey, I saw it's really interesting thing that you're working on there. Like, let's see if we can work with TELUS Health to do employee screening at large job sites." So, long story short, this is like a whole thing. We joke around. We need to write a book about this, but essentially, I took $1 million loan that we had to pay back in 12 months, and we had this agreement in the works with TELUS Health, and the check clears and the contract's being signed like March 15th, 2020, which of course is when the world shut down. So
oh no,
we're in a really interesting position where the company's great idea got off to a bit of a rough start, and so it had some debt. So we spent the lockdown periods like making the company debt free and really thinking deeper about the strategy. And what we realized was that as fantastic as the opportunity was to do the employee health screening, where we would have taken generating these reports from 40 days to about 15 minutes. As exciting as that was, we still came back to our belief in the pharmacy. But we were using a different instrument at that time, which was a very interesting instrument. It was called the Abaxis Piccolo. It took a much larger sample, and it didn't do HbA1c. And that instrument, it also was the company that it had been acquired several times, and they were focusing more on animal health, which is really interesting because the instrument originally was developed by NASA for the space station. So it had gone from the space station to human health and military applications, and then GP offices in the United States, and then now is focused on veterinary medicine. So that's an interesting case study in and of itself. But during that 2020 period, because I think destruction is the mother of all invention, and Abbott had reached out to us and said, "Look, everybody's kind of like had a chance to slow down, and you're kind of got a chance to look in the mirror. We really think what you're doing is interesting." And so we were able to integrate the Abbott Affinium, and that instrument brought in the ability to screen for diabetes, and uses about a 10% of the sample size. And so we were really excited by that, and we did a pilot for Shoppers Drug Mart, and that led to a scale-up agreement where we, at our peak, have been 800 locations across the country. Rexall as well has joined the network, and we're continuing to work to expand the network in Canada. over that period of time since 2019, I mean, we've tested 20,000 plus people. It's been really fantastic to see the amount of impact on patients and the practice of pharmacy. The challenge in Canada, of course, is that it's still not funded work. So
Sure.
the push in Canada is still relied a lot on the pharmacy groups of building this into their broader business case, which has worked really well. But what we have recently decided, we had signed last year the initial agreements to engage in the feasibility study with the NHS. But in 2025, we're moving a lot of our instrumentation over to the UK. And the reason being is that we really need to be and really want to be in a jurisdiction where the government is really backing pharmacy on this and really investing in the program and doing the kind of critical investment in the type of testing that we want to see. And as I referenced earlier, the NHS through the Pharmacy First program has already invested about 1.2 billion Canadian in this effort. And so that has been highly successful, focused largely on blood pressure checks so far. But what our current study is seeking to do is to build upon the success of the blood pressure checks and looking at hypertension, and then drilling down on those individuals that are noted to have hypertension, and then confirm their disease state with the blood test, and then manage them in the community and keep them out of the GP's office and the ER, of course. So we want to stabilize the individual with medication if necessary, and keep them out of that more expensive triage environment. So we've shown that we can scale up to a large number of locations in a short period of time. We think that the opportunity in the UK is going to allow us to also influence a lot of the current decision making that's happening across the channel and on continental Europe, where countries like the Netherlands and Belgium, Italy, and Spain are all actively expanding the scope of the pharmacist as well, and engaging in more point of care testing and early intervention and screening. And so we're very bullish on that future. We're hopeful that Canada will not just expand the scope of pharmacists, but fund them for the work. We want more Canadians to benefit from this. The first interaction with healthcare should be a test, not a heart attack or a stroke. And so this is a clear and easy solution. And we're very hopeful that 2025 will create a deeper environment where we can really expand this in Canada, but also in the UK.
Vitamin Lab revolutionizes personalized supplements, empowering health practitioners to create tailored supplement formulations that address each patient's unique needs. Bring personalized health to your practice and choose from over 200 professional-grade ingredients to create vitamin formulas that improve patient adherence and result in tangible outcomes. All ingredients are sourced from the world's most trusted suppliers, and Vitamin Lab provides hands-on support to help you formulate and launch personalization to your patients. Say hello to a new era of personalized supplement solutions. Go to getvitaminlab.com/personalized to save $100 off your first formula.
Oh yeah, definitely. I mean, I'm sure we'll see Canada follow in suit at some point. There seems to be significant barriers here to this type of proactive care. Can you speak to some of those barriers? Like, what is preventing us from investing in a program like this?
This is an interesting conversation because, there's a lot for us as Canadians to think about. And obviously, as you and I are having this conversation today, that the new American administration isn't even in office yet and threatening us with 25% tariffs. And internally, we definitely talk about why is Canada, from a productivity point of view, not keeping up? And why is Europe not keeping up with America? It's a relative thing to think about because it impacts our decisions about healthcare, our economy, and alike. Is that there is a reticence in Canada that is really built into the DNA of our culture, of being risk adverse to the point of actually creating more risk. And Britain, back to that example, was very much in that, again, until the crisis got to a point where they were now at a place where they have to make decisions. But in the UK, all healthcare decisions, nothing could happen unless it went through the GP's office. Like, it was just this pinch point where everything has to go there. And the argument from the College of Physicians and the various doctors' lobbies is always as much like in the profession of naturopathic medicine. I think you guys have obviously bore the brunt of a lot of this too, is that
For sure.
if anyone even remotely suggests the idea that, a doctor doesn't need, like a physician doesn't need to look at that plantar wart or to talk to you about eczema, or as I read it in a recent interview, just towards the tail end of the summer there in September, I think it was a Toronto Star interview talking about the expanded scope of practice of pharmacists and how physicians were pushing back on this again in light of a concern that they're saying where by expanding the scope of practice in Canada, you're essentially allowing for-profit care. That companies like Shoppers Drug Mart or Rexall or Walmart or whatever are somehow bringing a profit equation to our single payer system, as if a doctor's office is not a corporation and a company, or that, Well Health, one of the most successful healthcare publicly traded companies, is not any less interested in profits, right? I thought that interview was in statement by the College of Physicians in Ontario deeply ironic, because they, a couple of weeks before, were complaining about capital gains tax changes made by the federal government, right? So are you a corporation that's engaged in capital gains activities, or are you, a benevolent monastery simply, delivering healthcare? So I think, this is one of the challenges. The politics around this gets to the point, it feeds on our reticence to make a change for fear of making a mistake, to the point that it actually becomes the mistake, right? Like the fear of doing something actually becomes the actual risk. And I've enjoyed listening to a lot of, various both pharmacy leadership organizations, like the industry associations representing pharmacists, and of course the Canadian Medical Association and others. The language that they're using is heartening to hear. They want to focus on early detection and prevention. They like the idea of expanded scope for allied health, particularly groups like pharmacists, and giving patients more choice. But you don't need to study this any further. You don't need to, review this any further. Saskatchewan recently announced that it's going to allow 20 pharmacists in the entire province to engage in expanded scope of practice so they can review it, keeping in mind that for 15 years, Alberta has had a quite expanded scope for pharmacists. They can, prescribe. We don't. What do we study? Like, we don't. British Columbia was famous for it because we have a drug review process in British Columbia that is particularly inane, where there's umpteen studies of a particular drug. And some of these rare drugs, there's patients that want access to these rare drugs. They've been studied in 50 different countries. They've been, used successfully. But, of course, British Columbia wants to engage in another study, as if the results change. So, I'm not a type of individual that says that we should ever be laissez-faire. But I will say, or too laissez-faire about making decisions. I learned, having been a senior political staffer and advisor to cabinet ministers. I've worked in public affairs in the private sector and advised governments and First Nations and industry associations. I've been elected myself. I know firsthand that when you make a decision in public policy, there is always an unintended consequence, and it's a reality of the decision that you make. You're trying to mitigate that. But in slow walking investments in preventative health, we are investing in rapid, out of control healthcare costs related to things like chronic disease and cancer, because they end up being connected. It drags our GDP, and it invariably leads us to a crisis point where the healthcare system that we value so much, our universal healthcare system that we value so much in Canada, could very well be put at jeopardy. And so my hope is, whether it's in the economy or healthcare or whatever, is Canada has to balance its culture of decision making from being like, how cautious do we really need to be? Like, I just want to see decisions made based on evidence, and I think if the evidence shows that working with a naturopath improves a patient's life, why would we make an arbitrary decision to simply satisfy political gamesmanship? And if it's not about profit, to this point, if it's not about profit, then why prevent somebody from engaging in healthcare? Because you can't argue
Completely.
that they're going to kill somebody, right? Like, I saw that the Ontario Physicians College made a statement. Their spokesperson in an interview was saying that even a sore throat can be a life-threatening episode that a pharmacist could misunderstand and misdiagnose. I just, I don't know how you could make that statement.
It's bold. Yeah.
You're using health tab in a pharmacy, and that individual's bad cholesterols are off the charts. So they're at like a 6 or a 7. I mean, this person is a ticking time bomb for a heart attack or stroke. The healthcare system needs to be able to empower the pharmacist to refer that individual to a cardiologist, because the GP it's just an extra step. It's an extra step and expense, and it doesn't improve the patient's life or outcomes. What would improve healthcare efficiencies and better outcomes and efficacies for the patient would be the pharmacist has said, this person is a red flag. This person needs to speak to a cardiologist who can then walk that patient through and to identify what is causing the disease and then get them on the correct treatment plan. And so I remain hopeful that we can get there. But we really need to, as Canadians, be saying, let's make decisions based on evidence, and let's look at facts. Let's stop simply going on feelings or we've always done things this way. I mean, it really just should move in the right direction. But I'll say that I do, in an ironic way, think that the work that we're doing in the UK, even though we started in Canada and we proved that the model can work in Canada, we think that the work that we're doing in the UK should influence the conversation and policy in Canada and get them to see that these investments save lives, but will lead to significant savings in the billions of dollars over time that will ensure that we have more sustainability for this public healthcare system.
Yes, definitely. Definitely. For us, I see like the midwives in this province are provincially regulated and sponsored, and they've done incredible work. Really, really incredible. They got a standard of care. Millions and millions of families have benefited from the midwives' work here. And now we're seeing the nurse practitioners come on and do really great primary care work. So, our entry into this is right now the naturopaths are pitching about being a part of the harm reduction program for drug use and addictions in our province. And we think we could play good. They already had us doing vaccines and trained naturopaths to administer vaccines as part of the provincial program. Very clear standard of care. Here's what you do and when. Easy stuff. No problem. We handled it just fine. And now we're trying to integrate into that in that harm reduction program. So we'll see how that goes.
Well, having a lot of firsthand experience with that, it is definitely time. Like, the conventional recovery and the conventional way of dealing with people living with addiction it clearly needs to change. And as well intentioned as it was, and when I was on Vancouver City Council, we were pitched this idea of the vending machines for the dilaudid pills, and I did not support it. I just this was not
absolutely not.
I'm not opposed to harm reduction, but you need the 4-pillar approach, and you can't just be doing like the two of the pillars is the ones that we do now, which is just policing and harm reduction. We have to have education and prevention, the other 2 critical legs of the stool added to this. And in mentioning that naturopaths are going in this direction, I think it's great, because I think it would bring back this opportunity to that piece around true prevention and working with individuals in a more personalized way, which we know that they need. And look, I used to, when I was in politics, I used to say to people, if homelessness was about a lack of homes, we would have solved the problem a long time ago. We could just go build a bunch of houses or build a bunch of have a bunch of SROs. Problem solved, right? Clearly, that's not the issue. So crime is one of these things as well, where you. And again, I'm talking about these things because it's always thinking outside of the paradigm of simply like conventional decision making, but lowering crime rates actually has nothing really to do with putting more cops on the street. It's not how you actually reduce crime. So how do we produce healthier communities? I think it's we have to start functionally on how they're built. Are they supported within their community? Do they feel valued? Do they feel that there's hope? Do they feel that they're respected? And do they feel that they have a chance, basically? Like, do they feel that they can work towards something and that it's meaningful? If any of those things are missing, we know that people go down the wrong path. And it doesn't necessarily mean choosing alcohol or opiates. It could mean food. It could mean a lot of things. And the reality is that we're getting better at it, but we've been building communities that functionally breed bad health. Can't deny it. When we look at the rates of increase of addiction, but also the astronomical rates of the increase in chronic disease. Canada is currently spending about $38 billion a year just on chronic disease, like heart disease and diabetes. It is growing astronomically year over year. The UK is making these investments now, but it doesn't change the fact that 2-3 weeks ago, the NHS released another report that said that they've seen a 55% increase in strokes in people over 50 in that country, and a 35% increase overall. So, as a sort of, and hopefully not in too convoluted of a way explained, if we are to solve these issues, we have to think about how complacent we have become in approaching these issues, and be unafraid of putting our hand up. Or if someone else puts their hand up, the other Canadian thing is to shoot the messenger, right? So we don't, somebody says like, the naturopaths are like, hey, we can do something different, and the messenger gets shot. So we have to certainly embrace voices and conversations, and be unafraid and look at things from the fact. I don't think that's naive to say. I do believe that's possible, because there are lots of examples of cultural changes that we can make that we've made in the past around certain things that we know we can change. We'll close this up by saying that part of the way that we were able to scale up to our size and have the impact that we have is, I recognized early on, is that we had to really be thoughtful about the way that we deployed Health Tab, the way that we speak about it, the way that we acted as a company, even right down to even the way that it's designed, to think about the criticisms. Like, how is this going to be attacked? Like, how is conventional medicine going to go after this? From a public affairs point of view, like, how is can this go sideways? Because we wanted to completely de-risk it in the minds of any policymaker that was looking at this. And that goes to, as well, physicians and alike. Like, we're using laboratory grade instruments. We're the only point of care platform on earth that includes an external quality control audit done by a reference method laboratory. We're using the most advanced approaches from data security, and also the thinking of the software as well. Is the way that it's generating results is meeting the very highest and best standards. And of course, interoperability is very much a key concern for health policymakers and governments today. Only 6% of health data generated gets used. So if you think about the massive amount of data that is generated every day, from hospitals to doctors' offices to wearables to you name it, all this information ends up in by and large, a very siloed, very limited context. So it's not really acted on And so we're also a very open platform. So we've connected blood glucose meters to HealthTab now. So that means not only are you able to, as the practitioner, able to get information about the patient when they're conducting the test with them there on site, but if they are a patient with diabetes and are using a meter, they can actually see how they were doing in between those visits as well. And so we're going to be doing also we're going to be connecting to the NHS patient health record through a partner in the UK, which we'll talk about more soon. But there's another really great example that we are not trying to build silos and fences around and saying that we own patient data. We take our role as a steward, which is a technical term. If you get into this stuff, where you're classified as a steward of the data. We take that role very seriously, and we just try to be the highway. So like, how are we getting the information where it's going to be used to maximize? And we hope in conducting ourselves this way that policymakers and the various vested interests in the conversation will feel calm about it, feel confident that the pharmacist is going into this new practice area using the best standards a physician or a laboratory would use, and that this information can benefit them in their practice as well. And it's not seen as a threat, but it's seen as an opportunity. And so we've worked very, very hard at that, and I'm hopeful, and I believe that that argument is winning in a great way. But we still have to complete that journey.
Well, here you are. I mean, the proactive preventative medicine is the future, and objective data, objective analysis is the thing that inspires me the most. Along my journey, having as much data as possible is really what keeps me on point. And a lot of my patients, they simply come here because not only we try to be evidence-based, but we try to be objective. We try to treat the person in front of us. And this, we have, I'm in a strange position because people come to me already obsessed with their own wellness and trying to take care of themselves. And
there's a walking worried for sure.
Yeah. Exactly.
Well, that's a good point. That we think that the pharmacy is helping those people too. There's people that are like the biohacker, or there's the walking worried. There's a lot of people. Both my parents have passed away, and I think that they always seemed very standoffish with healthcare. I don't think that they felt that the system, they didn't like interacting with it. They didn't feel that it was a positive experience. And so if someone has a bad experience, and the big reason why point of care testing is exploding in a variety of different ways, is not just technological advancements, but the statistics of a physician or a naturopath giving a patient a lab requisition and them using it is like slim to none, right? They unless it's a real crisis point for that individual, they won't go. So you're much better off saying, well, how do we give them the information now, and how do we act on it now and use evidence? But you reminded me of something, is that part of my high blood pressure, figure out that I had high blood pressure journey. I was having like a neurological pain on the side of my head. And so I thought it was in my ear. So I went to a ear, nose, and throat specialist, and they looked at me and said, I don't know what it is, but we'll have you come back. And then they just ghosted me, and I had to use my GP to follow up. They just kind of well, I don't know what it is. So we'll just give up. And then I waited forever to see a neurologist. He gives me a 15 minutes, almost like roadside sobriety test. It's touch your nose, tap your head, jump on one foot kind of thing. And he's like, yeah, you're fine. But then he said something odd to me. He goes, do you want antidepressants? And I was like, why would I want antidepressants? I didn't come here saying I was sad. I was saying I'm annoyed that I have this pain that shows up on the side of my head sometimes. And I'm just I'm trying to solve it. So I leave that appointment. I have a follow-up with my GP, and I say, yeah, he's not listening to me the entire time. I'm telling him this thing. And then I'd say to him, the only thing he said to me was that asked me if I wanted antidepressants. And I swear to God, this guy he stopped typing, and he looked up at me and said, do you want antidepressants? And I was like, what is this? Like a candid camera or something like that? I don't understand what you're talking about. And it was doubly concerning for me, because talking about evidence-based care, that's what where that story comes from, is that, we've had different healthcare technology companies that generate data, and they would like to kind of build off the success of HealthTab and use it as an opportunity to get data into it and communicate with the patient. And so pharmacogenomics companies have come to us, and one was kind enough. Are you familiar with the term? You've heard precision medicine pharmacogenomics. So testing your DNA against a database of the most popular drugs and seeing from an efficacy point of view how you will react to it. I had my pharmacogenomics done by a company called Inagene, and in that report, everything was pretty much normal, medications are medications. But the one thing that was red flagged for me is to not take was antidepressants. So it's an example of, as strong as the convention has been, that if we allow anybody else but the general practitioner, the medical doctor, to deal with this issue, all hell's going to break loose. We're all going to die.
Right.
But in reality, we're doing this prescribing without evidence, prescribing without testing. And we're also doing what I call this sort of car mechanic way of dealing with healthcare, whereas we'll just keep on putting you on medications and we'll keep on doing things. And then if it doesn't work, we'll just try something else.
Mm-hmm.
If any of you have had a car mechanic that it's keeps on changing parts on your car, but doesn't solve the problem, but he's like, well, here's the bill. You know what I mean? So I think this is the issue within healthcare is the rhetoric is all been, we need to focus on prevention. We need to focus on precision. We need to focus on interoperability and collaboration. So both from a data perspective and also healthcare team perspective. And it's time for everyone to perhaps not simply make the argument, but to play a role, I would suggest, and naturopaths could play a role in this is, what language is it really going to take for people to hear us, whatever the practice is? Pharmacists have to think about this, nurse practitioners have to think about this, is that how do you overcome that convention, these assumptions and the fears? And it's time to be more evidence-based, and we're, as I said before, we're hoping to play a role in that. But my hope is that we'll get away from this current focus of just handing out pharmaceuticals to people without really having an idea of what they really need or what the issue is.
I think we will. Well, listen, Hector, this has been incredible. You opened my eyes to a lot of things today. I really enjoyed speaking with you. I want to thank you so much for your time. I know that with the work you're doing in the UK, I assume listeners will eventually be able to interact with HealthTab there. Canadians can interact now with your company. Where should we learn more about HealthTab?
Well, you can go to healthtab.com and you can find locations and you can find more information about it. And of course, there's Avricore. If you search the name up on the screen there, I think if you look us up there, you can see more of a high level as to what we're doing. There's some additional information there. And check it out. And obviously, hopefully get a chance to go into the pharmacy and experience it. And we'll be excited to share more soon. And we'll keep you posted on how things go in the UK. And we're looking forward to taking the NHS to the true prevention level. It's going to be great.
Absolutely. Way to go. Thanks so much for speaking with me today, and I hope to chat again soon.
Yeah, thank you very much, David.
Bye.
Thanks for joining us for today's discussion. What about today's podcast resonated with you? Be sure to tag at Dr. David Dizer and at Get Vitamin Lab. If you're learning from and enjoying this podcast, please let us know by subscribing to our YouTube channel and follow the show on Spotify and Apple. And don't forget to leave us a review. It's the best way to support our podcast, and it helps others find us. To learn more or book a demo to explore what personalization could do for your practice, please go to www.getvitaminlab.com/personalized.